Good evening. Welcome to this seminar dedicated to COVID vaccine. It's a great pleasure that Welbeck wanted to bring us all together this evening. And it's a great pleasure to have Professor Regan with me. I'm going to start with the Allergist take on the COVID vaccine, and hopefully I'm going to answer quite a few questions that you might have, because I know that concerns related to allergy and vaccination have been making your life really difficult. So let's try to make it easy. I'm a consultant allergist at Welbeck. I'm also a consultant allergist and clinical lead for adult allergy at Guy's and St. Thomas's. And I do look after patients with drug allergy as well as patients with suspicion of allergy to COVID vaccines. So I'm trying to advance my slides, and they are advancing. Here we go. So I think by now everyone is familiar with this structure. This is the COVID-19 virus. And this cheerful lady was the first person in the world to receive the Pfizer COVID vaccine. It happened in early December in the UK, so we are sort of leading the way. And as you know, we have vaccinated more than 30 million people now. And just like with any medication, you can definitely expect an allergic reaction. So that's the first thing to say. Adverse allergic reactions to any vaccine are expected, and there is nothing really to be worried about. But we need to understand how to manage them, how to reassure our patients, and how to make sure that they are not denied vaccination for no valid reason. Currently, we have 3 vaccines licensed in the UK. We have the so-called Pfizer vaccine, Moderna vaccine, and AstraZeneca. And when you think about any vaccine, it always contains the active ingredient, so the ingredient that is meant to induce immune response and offer protection. But obviously, any vaccine or any medication contains excipients and different additives. So when you think about the composition of the vaccines, apologies for this red box that seemed to have moved. When we look at the Pfizer and Moderna, they are mRNA-based vaccines, and they both contain polyethylene glycol, or PEG. AstraZeneca, it's a slightly different mechanism of inducing immune response. And the excipient that you will find in AstraZeneca is called polysorbate 80 or PS80. So we know that reactions are never or almost never caused by the active ingredient. If we have a patient referred to us with a history of anaphylaxis to a vaccine, we usually tend to focus on additives. And of course, everyone these days is talking about PEG, and everyone is talking about polysorbate 80. I bet you've had many patients who said to you, I had different reactions to medication, I must be allergic to PEG. Or patients come to you and say, I'm allergic to polysorbate 80, therefore you cannot give me the AstraZeneca vaccine. What is PEG and what is polysorbate 80? So, you know, a little bit of chemistry on my slide now, and don't worry, I'm not going to go into details, but polyethylene glycol shares certain structures with polysorbate 80. We know that polyethylene glycol is contained within different medication, and this is the so-called hidden allergen. It's very easy to forget that it exists. Allergy is very rare, and there is concern that patients who are allergic to polyethylene glycol can also be allergic to polysorbate 80. They are found in different medications. Polyethylene glycol, not in many, but you might be familiar with some of them, which I bet you use in your everyday practice. One of them involves Depo-Medrol or methylprednisolone with polyethylene glycol. You might be familiar with Depo-Provera, the contraceptive agent. Some of the other agents are used less commonly, but overall polyethylene glycol is not found in medication that often. Polysorbate 80, on the other hand, is available in around 6,000 different drugs approved by FDA, and polysorbate 80 is also found in different foods. So if we are concerned about an adverse reaction to a COVID vaccine, usually we focus on polyethylene glycol, but we also never forget about polysorbate 80. There are different reactions to vaccination, and this applies to any medication. You have your immunologically mediated reactions, which can be immediate, such as anaphylaxis or immediate onset urticaria, or it could be a delayed reaction, for example, a large localized swelling at the injection site. And of course, there are also some reactions where the mechanism is not clear, or the mechanism is not really within the realm of allergy. So you can have patients who present with serum sickness, you have patients who present with more systemic response, but I am going to focus on type 1 hypersensitivity, which is anaphylaxis, and briefly talk about type 4 hypersensitivity, the delayed, localized, or more generalized reactions to one of the vaccines. The good thing is that if you have a patient who comes to you and starts talking about medication allergy, the Green Book of Immunization, which you can access online, and the address is at the bottom of the page, makes it very easy for all of us who are responsible for prescribing vaccination or actually administering vaccination or supervision of the vaccination hubs. Do not give the vaccine to anyone who has a confirmed diagnosis of polyethylene glycol allergy. It's going to be very rare. But there are some patients who might show you a letter from the allergist that says, this is something that I should never have in my life. And of course, we never give it to a patient who says, I had anaphylaxis that required adrenaline after the first dose of one of the COVID vaccines. That's what the Green Book suggests. But of course, we don't want to close the door to our patient. We don't want to say, we will not give you anything. This is where we need to think about referring our patient to an allergist or an immunologist, depending on your local support network. And this slide is in a way one of the most important slides that I'm going to show you this evening. It is something that I have taken from the Green Book of Immunization. The Green Book is updated regularly, but the allergy update, the most recent allergy update was in February 2021. So if we concentrate on the green section of the table, these are patients who can be vaccinated in the community without any special precautions. So if your patient says to you, I had a crushing anaphylaxis to penicillin, that's perfectly all right to vaccinate them. If somebody says I had anaphylaxis to wasp or bee venom and I have undergone immunotherapy, or if I'm allergic to aspirin, or perhaps there is a family history of allergy, you can reassure them and just say your risk of reacting to any of the COVID vaccines is like anyone else's in the population. It's never zero. That's something that we always have to be open about with our patients. It's never zero. But if we give them amoxicillin to take home, or if they go to get a tablet of ibuprofen from the local supermarket, they don't worry about anaphylaxis, they just take it. And if you have no significant allergy history, the same applies to vaccination. Patients with mastocytosis, which is a condition where our patients have too many mast cells and they can have spontaneous unprovoked anaphylaxis, we know that they can be vaccinated in the community, and it's based on our experience in the UK and also on the experience of our European and American colleagues. So penicillin allergy, ibuprofen allergy, food allergy, peanut allergy, wasp venom allergy, do not worry, they can be vaccinated. And then if we look at the red section of the table, again, that's quite clear. If you had a reaction to the first dose of your COVID vaccine, of course, we're not going to just vaccinate you in the community. You might have to ask an allergist for advice. Or if the patient has a history, as I mentioned earlier, of allergy to polyethylene glycol or polysorbate 80, it's great to talk to an allergist. And I'll show you in a second what we can do to facilitate vaccination. The difficult situation, and I know that you guys are really, really inundated with questions, because within my NHS part of my job, we provide advice and guidance, an advice and guidance system for the GPs, and we get hundreds of questions every single week. What do we do with a patient who says that they had a reaction to a penicillin drug, to ibuprofen, for example, and perhaps to injectable contrast? We can say that this was anaphylaxis to multiple unrelated drugs. Are they perhaps allergic to PEG? What about a patient who says, I was 5 when I had anaphylaxis to DGP, and now I'm 37 and I need to be vaccinated, and nobody will touch me because they are worried that I'm allergic to vaccination? Or what about patients who say, I had idiopathic anaphylaxis? Idiopathic anaphylaxis suggests an anaphylactic reaction where no cause has been found. But we are talking about patients who come to you first, right? They haven't gone through an allergist. So you have to make this decision very often with the patient in front of you. And this is where things can be difficult. So if you have a friendly allergist or immunologist in the private sector, or if you have an NHS sort of network of support and your practice can escalate to your local hospital, please ask. Because very often we know the so-called allergy to multiple medication has nothing to do with allergy. Your patient has diarrhea to penicillins, that's a side effect. Your patient, for example, bled from their stomach when they took ibuprofen, that's definitely not allergy. And your patient had a large swelling of the arm when they received a tetanus dose. This is not multiple anaphylaxis. These are side effects and perhaps a bit of localized allergy mixed up. But your patient very often comes with a long list of problems, and then you are unfortunately put on the spot and told, right, what do I do now? Ask your allergist, ask your immunologist. 99% of patients will be able to give you the go-ahead, even without any tests. A patient with idiopathic anaphylaxis, of course, they need to be referred according to the NICE guidelines. They need to be sent to an allergy center, and we're going to work them up to try to find out, are there any hidden allergens? Do they have mastocytosis? Or is there perhaps a non-allergic explanation, and the so-called anaphylaxis perhaps represents episodes of syncope due to a cardiac arrhythmia? But once you've spoken to an allergist, in most cases, you're going to hear from us, it is all right to vaccinate in the community, but you might want to give your patient a longer observation period. You might want to pre-medicate with antihistamines, but of course, we need to be open about the fact that antihistamines do not stop anaphylaxis. They can prevent skin rashes, urticaria, flare-up of eczema perhaps. They can offer this sort of psychological comfort blanket, but they will not stop anaphylaxis. But most cases of suspected multiple drug anaphylaxis are usually not anaphylactic at all. So this is in a way the most important slide, as I said, from the Green Book of Immunization. It offers lots of information and it makes your life much easier. And of course, it makes the life of our patients much easier because they get what they want, which is they get vaccinated in the community rather than waiting months and months to see an allergist and travel to a distant hospital to have vaccination under supervision. But of course, you've done the questions, everything went well, but then your patient actually receives the first dose and things don't go as planned. So let's say you've injected them with a dose of AstraZeneca or Pfizer, and your patient after the first dose has anaphylaxis, difficulties breathing, dizziness, wheeze, vomiting, diarrhea, literally within minutes after you injected them. Then of course you need to refer them to an allergist. You cannot just say, well, I'm going to give you another dose. But if your patient develops an immediate onset swelling or perhaps some urticaria at the injection site, there is no concern. When the time comes, give them the second dose. You might want to give them an antihistamine or just observe them for 30 minutes. There are many patients who say, I had a delayed reaction. I got my shot at 10 a.m. on Wednesday. On Thursday afternoon, I was covered in eczema and hives. And of course, if the reaction was self-limiting or perhaps responded to an antihistamine, again, they can be vaccinated in the community. They might need an antihistamine. And this is because very often it has nothing to do with the vaccine. It could be a flare-up of their underlying urticaria or eczema. But if your patient develops delayed onset angioedema, let's say within 24 hours, of their lips, of their tongue, of their throat, and they end up going to A&E asking for help, then again, you can't just vaccinate again in the community. You might want to ask an allergist or immunologist for help. But if you look at this flow chart, again, it makes everyone's life very easy because a bit of redness, a bit of swelling, a bit of discomfort usually does not suggest anaphylaxis. And we know this because we advise our GP colleagues to vaccinate patients in the community, and they do it successfully. We do it ourselves as well at Guy's and St. Thomas's. We just do it without any problems. And very rarely do you actually find out that the patient is really allergic to the first dose of the vaccine. And then perhaps you need to bring them for a more thorough allergy workup. I just want to prepare you that now that Moderna vaccine is available, for example, at Guy's, we started last week, we're going to continue next week, and I bet you're going to have it in the community as well. We know about the so-called Moderna arm or COVID arm. Many patients, especially in America, develop delayed onset, localized, sometimes painful, sometimes itchy, erythematous, sometimes painful and swollen area that can persist a few days, and it can also start a few days after vaccination. And of course, this is going to be of concern to the patient and might concern you as well. But our American colleagues who've been doing Moderna vaccine for many months now, they have clear evidence that this is not a reason to avoid further doses of Moderna. We know that the patient can have a similar reaction again when you give them another dose, but they do not have anaphylaxis. You might want to treat them with antihistamines and prednisone if it's really bad for a couple of days, but they can be safely vaccinated in the community. And I'm just preparing everyone now because Moderna is coming. There is less Pfizer, there is lots of Astra, there is Moderna, there will be 2 more vaccines soon, but Moderna arm, we know about it, so please don't be concerned if you see it. And I bet we're going to have lots of questions about this coming to our vaccination support hub. And this is taken from a paper in the New England Journal of Medicine, where our American colleagues documented those delayed reactions in patients receiving the Moderna vaccine. All those patients, or most of them, were vaccinated, receiving another dose of the same vaccine. Nobody had anaphylaxis, and if they had a flare-up of the delayed reaction, it was less severe. So this can be done in the community. At Guy's, we are still one of the largest vaccination centers in the country. I'm talking about, sorry, in London, I'm talking about NHS hospitals, not community hubs. So we have this support network, which means if the vaccinator, one consultant in charge of the hub, where hundreds of vaccines are given per hour, if they have allergy concerns, they will always be told, have you consulted the Green Book? And if exclusion criteria have been met, they refer the patient to us. If the Green Book criteria are not really of concern, but there are other allergy concerns, we provide an on-call service. And then Monday to Saturday, the vaccinator or the consultant in charge of the vaccination hub can call us, and we are going to provide advice on the phone. And in 99.9% of patients, we're going to say, go for it. We don't have any concerns. We can vaccinate in the hub. And we get feedback straight away because they get vaccinated the same day, the same minute, really. And we haven't had anyone come back to us saying your advice was wrong. In a small percentage of patients, we're going to think, you know what, it's really confusing. We want to talk to the patient, and we arrange a phone consultation with them. And then again, after the phone consultation, I would say in at least 95% of patients, we're going to be able to say, it is perfectly all right for you to have the vaccine in the community, because what you thought represented allergy has another explanation, or your allergy perhaps is not as severe as the patient thought. In a very small percentage of patients, we're going to say, no, we are still concerned. We think that you may have had an allergic reaction, or perhaps idiopathic anaphylaxis, and nobody knows what happened. And we're going to bring you to our vaccination hub, the allergy day case unit, where depending on your history, we're going to do the relevant tests. And I can tell you that I tested this protocol, for example, this morning. I had 12 high-risk patients who had a history of an adverse reaction to the first dose of the vaccine. And we have been able to test them using the excipient skin prick test reagents, and we were able to successfully vaccinate every single one of them. In some of them, we diagnosed polysulfate allergy, and we gave them the PEG-containing vaccine, and the other way around. So out of 12 who otherwise would have been denied the vaccine, after an allergy workup today, we gave them the vaccines, and everyone tolerated them. But this is a tiny, tiny fraction of patients we get asked about, and very, very few patients. So if you contact us, very often we're going to try to empower you to say you can do it in the community, and we can provide information and advice. So vaccination against COVID is here to stay. The government is talking about boosters, is talking about annual vaccination. There is lots of anxiety related to vaccination. Many so-called anaphylactic reactions represent a vasovagal reaction. There is an enormous emotional burden. Patients coming after months and months of self-isolation, coming to see you for the first dose of the vaccine. The emotional burden is so significant that sometimes, they have unexplained reactions that can be misinterpreted as anaphylaxis, but there is nothing organic wrong with them. And of course, our job as physicians is to facilitate vaccination. And as an allergist, obviously, this is something that I love doing, and I'm very happy to advise my colleagues. So if you are stuck with a vaccination patient, you don't know what to do. If it is an NHS patient, try to contact your large hospital. If it is your private patient, of course, you can contact us at One Welbeck, and they will be delighted to help. And if you have any questions, there will be time to discuss them after the next presentation. I can see 2 questions in the question and answer box. So let's see. So the first question is, in a patient with a penicillin allergy, non-steroidal anti-inflammatory allergy, and sulfur-containing medication, do they need to take any precautions? The answer is most likely not, but I would like to understand more what kind of allergy they have. Is penicillin perhaps diarrhea, and is non-steroidals a bit of angioedema? So I would need more information, but usually the answer would be, please do it in the community. You might want to pre-medicate with antihistamines. And then the question about where is the allergy day case unit, this is something that we do at Guy's and St. Thomas's, but only for the NHS patients. But many other hospitals have the same thing. At One Welbeck, obviously, we can offer allergy workup. We can test your patients for the excipient allergy, so we can sort it out for you. Currently, we are not able to vaccinate at One Welbeck because, as you know, the vaccines are controlled by NHS England. But who knows? Who knows? At some point, it might change. So allergy day case unit, this is the name of this sort of my unit, but it's often available in other hospitals as well. So thank you very much for your attention. And I think now we can move to Lesley's presentation. And then if you have questions, please ask away either directly during tonight's presentation, or I'm very happy to answer email questions if you have as well. Thank you very much.
So thank you very much indeed, Chris. That was absolutely fascinating and I learned a great deal and very, very valuable. And I hope that we can offer a vaccine to these patients when we've made the right sort of insights to NHS England. So I'm going to talk a little bit about fertility myths, and I'm going to start off by reminding you that we have to talk a little bit about what happens to women with COVID during pregnancy before it makes any sense of are there safety issues that we've got to consider. So before I can talk about the fertility and the pregnancy myths, I just want to quickly talk you through the data about what happens to pregnant women when they get COVID-19. Now, of course, this isn't just my thoughts. I'm going to pay tribute to all the people who've done so much work in this field. I'm going to remind you that the problem about pregnant women is that everyone's always scared of giving them drugs or vaccines. So we're always way behind when it comes to trials. We're always on the back foot. But thanks to the UK obstetric surveillance system, thanks to Wellbeing of Women, the charity, and thanks to the Royal College of ONG and the Royal College of Midwives and the JCVI, we're now collecting data fast. And I think we can be very definitive and very reassuring about vaccination for COVID in pregnancy. And I want to pay tribute to these two fantastic women, Marion Knight, who's Professor of Epidemiology and a physician in Oxford and heads up UCOS and Embrace, and also Professor Lucy Chappell, who is head of the Vaccine Hub and the COVID-19 Pregnancy Hub at the RCOG. And I think I might be one of the first people able to say in public, congratulations to Lucy, because this morning it was announced that she's going to become the very first ever female Chief Scientific Advisor to Her Majesty's government. So congratulations, Lucy. And I live in hope now that women's health is going to get right to the top of our government's agenda. So on to my topic for tonight. Let's talk about what happens to COVID-19 in pregnant women. And we've got to remember that there are direct effects of this virus affecting the woman. And then there's some very, very important indirect effects that occur to pregnant women that don't happen to other women. Fear of getting COVID-19 and the changes they have to their care. So the overall impact of COVID-19 is not just to do with getting infected, it's what they can't access in terms of normal antenatal and postnatal care as well. Now, this is a study, a whole year's data, looking at the numbers of women who are positive for COVID-19. The dark green is the symptomatic women, the lighter green or grey is the asymptomatic. And here we're going from week 1, which was the 1st of March last year, 2020. You see where universal testing came in. You see where December the 1st is. And you see how, as the year has gone on, the vast number, or rather the large number of pregnancies now that are infected are asymptomatic. And we now know that for every admission to hospital, there are another 100 women giving birth without complication. Sorry, I've gone on one step too far. This, however, is the really important slide, I think, when we're considering the problems of pregnancy and the fetus that's infected by COVID-19. And that is the symptomatic women who come into hospital prematurely or preterm. And many of them are delivering prematurely. And as those of you who know or remember your obstetrics, being born prematurely is the most dangerous thing that can ever happen to a human being. We get a bit blasé about it with our very posh 21st century neonatal care, but it is risky. But those women who come into hospital at term and are asymptomatic, they don't have very many problems. What makes women more likely to be admitted to hospital with COVID-19 in pregnancy? Well, it's that trio again. Older age group, greater than 35 years, BMI in excess of 30, and Black and Asian minority ethnic groups. And this is very like SARS back in 2003, where we saw very, very severe respiratory disease and very severe infections in women who were pregnant, and a very large number of deaths. Now, this is the outcomes for pregnant women if they are admitted with COVID-19, and this is data over the whole year. We know that 18% of symptomatic pregnant women require respiratory support, 10% receive critical care. Fortunately, only a small percentage die, but it's still 0.6% die. And of course, these are young women. And these are selected outcomes comparing December of last year to February of this year, compared to an interval between March and November last year. So this is actually looking now at selected respiratory outcomes for young women who are pregnant, who got the B117 variant when it became more predominant, so the younger age group one, and they're much more likely to require respiratory support, and the numbers of deaths have increased as well. So overall, for pregnant women and infant mortality, 21% of symptomatic women gave birth preterm versus 10% of asymptomatic women. And that's a very large number. That's 1 in 5 of those symptomatic women having a premature birth requiring neonatal care. Only about 21% of the infants were admitted to a neonatal unit, and interestingly, very few neonates actually had a confirmed postnatal infection. So less than 1% of those neonates born to infected mothers who had to be hospitalized because they were so sick had the infection. So the indirect effects of COVID that I alluded to earlier, well, I think we have to give real thought to the mental health issues before, during and after pregnancy. And remember that these are superimposed over the perinatal mental health burden that is associated with pregnancy in the first year postpartum. 1 in 5 women, we used to say, would be affected. We know that this figure is increased. We know that antenatal care has been very adversely affected, and antenatal care is there for a reason. It's a preventative intervention. It's important for early detection and treatment of disorders like preeclampsia and diabetes. And we also know that postnatal care is absolutely crucial, support for breastfeeding, early parenting. And we know that depression and mental health problems usually are at their worst in that postnatal period. And women are feeling very isolated at the moment. So when we're going to go on to talk about vaccines, we've got to balance our choices between benefits and risks when making decisions about what we should be advising the pregnant women or the postpartum women that we're looking after. So let me summarize quickly. From March 2020 to February 2021, we know that 1 pregnant woman admitted with COVID-19 for every 100 women giving birth. Most women who had to go into hospital because they were really sick did so in later pregnancy. Less than 50% of women having a baby have got symptoms. They're being assessed because they've gone into hospital, so they have to be tested. Of those with the symptoms, 10% need critical care, less than 1% die. That means that more than 90% of women admitted to intensive care do recover. 1 in 5 women admitted with symptoms have a baby born prematurely, and that is a very significant problem. But fortunately, very few babies get COVID-19. So I would suggest to you that the magnitude of risk in pregnancy may be higher from the indirect effects, such as lack of antenatal or postnatal care, and the massive increase in the mental health problems. So those are things that we've got to factor in. Now, if you're wanting more up-to-date information, and of course we know this is changing all the time, please go onto the RCOG website. The guideline cell is updating every month. This slide just dates back to February 2021. There's a new version from April 2021. It's being updated all the time. It's easy to download, and they've got lovely algorithms and careway charts that you can follow easily. They don't just look at the figures I've shown you. They give great detail about how you can provide antenatal care during the COVID-19 pandemic, how you can make up for the fact that so many women are not going to antenatal clinics. They talk about venous thromboembolism prevention, how you can prepare women for labour and birth during the pandemic, and how you can manage clinical deterioration during the pandemic. Now let's go on to vaccines, and this is a photograph of me because I'm part of the Imperial College Vaccine Hub, and I've been vaccinated quite a lot of the Welbeck staff with the Pfizer-BioNTech vaccine, because that's the one we've been using at Imperial because we have cold storage facilities. So happy to answer any individual person's queries. If you want to email me, l.regan@imperial.ac.uk, or you can mobile me. So Chris already told you a little bit about the 3 vaccines that we've got in the UK to compare them. The Pfizer-BioNTech, which is an RNA vaccine, as is the Moderna one, and the Oxford AstraZeneca one, which is the viral vector one. And they have particular storage requirements, which often dictates where you will be able to send your patients. So for example, in a hospital like Imperial College, where most of those with cold storage are using the Pfizer-BioNTech, and the regular fridge temperature is much more likely to be used in GP surgeries, for example. And this is the vaccine rollout and the implications it has for pregnant women. You will remember these risk groups from 1 to 9. Remember, frontline health and social care workers, clinically extremely vulnerable individuals, and then number 6, all individuals aged 16 years to 64 years with underlying health conditions which put them at higher risk of serious disease and mortality. Now, pregnancy in itself doesn't put you at serious risk of, or higher risk of serious disease and mortality, but some of the disorders of pregnancy, such as gestational diabetes, preeclampsia, women who are very obese, women who have rheumatological problems, autoimmune disorders, are in that group. And so they are very anxious about what they should be doing about the vaccine. So are COVID-19 vaccines safe in pregnancy? And I would really strongly advise that you go and read this very short and very digestible article in Nature Reviews Immunology, published very recently by Vicky Mail. It really is extremely sensible, talking about how many young women are hesitant to accept the vaccine because they are citing concerns about fertility. There's been a lot of social media coverage about this. And I could share with you that one of the individuals that put about this, that fact that the Pfizer-BioNTech vaccine caused infertility, was a very disgruntled, recently fired Pfizer worker who'd been sacked because of embezzlement or fraud. I can't remember which it was now, but then as a revenge posted this on social media and on Facebook. So data on accidental pregnancies that occurred during the COVID-19 trial rollout and increasingly outcomes in pregnant women, pregnant people who've received the vaccine, can now help us to make informed decisions. So the data are now accumulating and they are extremely reassuring. So yes, I would say that they are safe in pregnancy, but let's look at a little bit more detail. If you've got patients who have got fertility problems or are worried because they're going through fertility treatments, the British Fertility Society has got a great source of information that you can share with your patients and will be very helpful. Again, very, very reassuring. And again, I'm coming back to the RCOG website. This is a joint statement, an emerged information sheet between the RCOG, the Royal College of Midwives, the UK Teratology Information Service, and the MacDonald Obstetric Medicine Society. And I'm just going to read a few points on this slide. I'm pregnant and I've been offered a COVID vaccine. What are my options? And I think now we're saying, really, you should be getting the vaccine in pregnancy. It's your choice. But I think overwhelmingly now the data is showing that this is a very sensible thing to do. Who can be vaccinated? Well, this has been a fast-moving or fast-changing seed, and you'll see that this slide is dated as of the 16th of April, which is actually last Thursday lunchtime, when the new guidance came up from the JCVI that COVID-19 vaccination should be offered to the following groups of pregnant women: those with high-risk medical conditions who therefore have a greater risk of severe illness from COVID-19. And if any of you have seen women who've been pregnant and had a serious, been seriously ill, you will realise how crucial it is to try and get pregnant women vaccinated. Those pregnant women who are health or social care workers because they are at increased risk of catching COVID-19. People considered at high risk of COVID because of their health and personal factors that include age, ethnicity, BMI, and underlying health conditions. That's all those pregnant women that I read out from priority group 6 in one of the previous slides. And specifically, women diagnosed with gestational diabetes in pregnancy, or pregnant women with a BMI of more than 40, and women aged 45 or over. Now, you may think that sounds a bit fanciful, but with assisted fertility treatments, we know that there are many women now who want to be pregnant or are going through fertility treatments and having successful pregnancies over the age of 45. So as COVID-19 vaccines are made available to younger people in the general population, they're also going to be made available to pregnant women in those age groups too. And I would suggest that you strongly encourage your patients to get vaccinated. Now, there have been some recent concerns about the AstraZeneca vaccine, and this is because of this extremely rare idiosyncratic reaction to the AstraZeneca. Very, very rare, but obviously because of that, it's been a source of great concern. So this is a slide that's actually come from the Winton Institute in Cambridge, which is actually trying to weigh up the potential benefits, that's the left-hand side of the graph in blue, and the harms of the AstraZeneca Covid-19 vaccine for 100,000 people with medium exposure risk. So not healthcare professionals, medium exposure risk. And you'll see down at the bottom of the slide that at 60 to 69 years, there's a massive benefit from having the AstraZeneca Covid-19 vaccine, which you go up the slide to the younger age groups. In every age group, there is still a benefit outweighing the risk, but the benefits are less of a margin than they are in the older people. So that means that down at 20, 29 years of age, the potential benefits of having the vaccine are 2.2 and the specific blood clot risk of potential harm 1.1. Now, it's a very complex type of abnormal idiosyncratic reaction. This is not the thrombosis that occurs is not like the blood clots that you get usually in pregnancy. In fact, it's a very atypical autoimmune derived problem, but it's caused an enormous amount of anxiety. But still, as you can see from this slide, the benefits of the AstraZeneca Covid-19 vaccine vastly outweigh the potential harms. So I would say that when you're talking to pregnant women about their fears for themselves and for their babies, that the benefits of vaccine really do weigh in their favour against the risks of the vaccine, which are very, very small. Now, this is a survey that the RCOG recently performed, and I think it's quite useful because this is the reasons for accepting a vaccine if it was going to be offered from women who've not been offered a vaccine yet and saying that they would definitely accept. Most of it's because they want to have the vaccine to protect vulnerable people they're looking after, or their family or friends, or to protect their baby, or to protect themselves, or because they recognise they've got other serious illnesses that COVID-19 may exacerbate and make them at serious risk of morbidity or even mortality. And these are the reasons for declining it. Respondents who've not yet been offered but would definitely decline. And you see here that worryingly, it's that they're worried that the COVID-19 vaccine will harm their baby, and yet there's absolutely no evidence that this is the case. That's the least likely thing to be happening. It doesn't increase the miscarriage rate, the stillbirth rate. It increases the prematurity rate, but it's not actually going to harm the baby in terms of an abnormality, causing it to have an abnormality. Some of them are worried that the COVID-19 vaccine will harm them, and others say that they want to wait for more information about the safety of COVID-19 vaccines in pregnancy. But if you remember that slide I showed you, looking at that data of those women who were being hospitalized and were critically ill from December 2020 to February 2021, they were the much younger women. So we really do need to try and address this and try and talk to them about their risks and try and reassure them. And this is one of the reasons in this last slide I'm going to show you from that RCOG survey why it's so important for us to be talking about this tonight, because this is a slide showing which healthcare professionals pregnant women want to go to for their advice. And you'll see it's GPs, midwives and obstetricians that they trust most to get their information from. So I hope that I've been able to give you some information for which you can share with the patients that you're caring for, and hopefully reassuring them about their pregnancy, about the outcome for their baby, and really reassuring them of the great importance of getting vaccinated as soon as they're offered a vaccine, if at all possible. And I would just finish with a request that we always think now in future about including pregnant women in research, particularly this COVID-19 research. And you won't be surprised to hear that Marion Knight and Lucy Chappell were major authors on this BMJ report that came out just a few weeks ago, encouraging everybody to include pregnant women in research so that we're not on the back foot in the future years when we're dealing with other variants or whatever, that we really are in a position to give them the very best of advice. So I'm going to finish there. I've got some questions that I've put up on some slides if there are not specific questions that the audience would like to answer, but I'll hand back to you, Rupal, and thank you very much.
Thank you, Professor Regan. I think you've covered that extremely well, so well, in fact, that you've covered the majority of questions. So I do have one from Dr. Charlotte Levy, who's asked, what would you advise to a woman in her 6th cycle of IVF and is just pregnant, who has been invited for the vaccine. She's already had her first, and although the advice is to give the vaccine, this is an emotive time. What would you suggest, Lesley?
Absolutely, go ahead with it. And if I can just move on a couple of slides, Charlotte, this is a question that's very, very frequently asked. So I'm going to move on one more. Can I start my fertility treatment? How soon after a COVID vaccine can I start my fertility treatment? Answer is immediately. You don't need to delay your fertility treatment unless you wish to have your second dose before pregnancy. So the only reason to delay having the vaccine is if you've decided you want to have your second dose before you embark on pregnancy, which I think is what I would prefer to do. This is something about, should I delay my fertility treatment until after I've had the COVID-19 vaccine? And here, the only reason to consider delaying fertility treatment until after you've been vaccinated would be if you wanted to be protected against COVID before you get pregnant. So the chances of successful treatment is unlikely to be affected by a short delay, Charlotte, but for example, of up to 6 months. But if you're in the older age group of women where even months and half a year, say, may increase your chances or reduce your chances for successful outcome, you may want to, your patient may want to come and talk to you a little bit more about balancing up the risks. But overall, no, if you're having fertility treatment, it's a very emotional time, but you should definitely get vaccinated. It won't harm you. It won't have any adverse effect on the fertility treatment. It won't hurt the embryos or anything like that. And it will protect you and ensure you're not one of those disaster cases coming into hospital, having a premature birth and being critically ill and needing respiratory support on a ventilator. Back to you, Rupal.
We don't seem to have any further questions at the moment, so
one question that I'm often asked, because I run a miscarriage service, is I've had recurrent miscarriages and I'm now trying to get pregnant again. Should I postpone having a COVID-19 vaccine? And I can say absolutely emphatically no. There's no reason to postpone having your COVID-19 vaccine, as it's not going to affect your risk of having a miscarriage, and it can't possibly be a cause of repeated miscarriages. So reassuring on that front as well. Don't know if I can go back. I think I said that already. And then, should people of reproductive age receive a COVID-19 vaccine? Yes, and I hope that we're moving down those age groups as quickly as we possibly can, that the vaccine program can roll out. Yes, people of reproductive age are advised to have the vaccine when they receive their invitation to go, and it includes those who are trying to have a baby, as well as those who are thinking about having a baby, whether that's going to be in the near future or in a few years' time. Now, because I run a miscarriage service, I often see women who say, oh, I've suddenly found myself pregnant, I've been invited to have the vaccine, I better cancel it. And I say, no, you don't cancel it, you go and have it straight away. And then you ask to ensure that you get the call back for your second dose at the earliest opportunity. It can't harm your pregnancy at all. The only thing that can really harm your pregnancy is if you get COVID, and you are one of those unlucky women who get it seriously, need to be hospitalized and are very, very sick. Back to you, Rupal, or to Chris.
Chris, do you have anything further to add?
I don't think we have any other questions, but I mean, I loved Lesley's presentation because I've learned a bit about the topic that I don't often come across, so that's very useful, thank you. But also I think another sort of practical observation based on the questions that I get from our general practice colleagues is about urticaria and angioedema. So obviously these are very, very common conditions, hives and swellings, and you're going to have lots of patients who are going to say to you, well, I don't want to have it because it's going to I'm allergic, I'll react to different things. And it's so important to reassure your patient and just say, look, you have a skin condition, you can pre-medicate, we can treat it. And even if your urticaria flares up after you've had a dose of AstraZeneca, because it can, or the Pfizer vaccine, there is no reason to think that you are particularly allergic. It's about empowering patients and telling them there are ways of managing it, but also trying to take fear out of the equation, because there are so many people who are unnecessarily worried. And overall, I think our position, as Lesley mentioned, is to try to vaccinate as many patients as possible. And the number of people who actually cannot have it is minimal. It's really minimal. And I think cooperation with your hospital colleagues, you know, whether it's an obstetrician, gynaecologist, allergist, immunologist, I think we can help with so many questions, and then patients can be vaccinated, you know, and help us return back to normal. Because I think that's what everyone is extremely keen to do. And the other thing is that you might come across is your patients telling you, I had an allergic reaction to the flu vaccine. Flu vaccination contains polysolbic 80. But of course, like anything in allergy, there are lots of exceptions. And actually there are years with, for example, 2019, when often there was no polysolvate in the vaccine. So the brand matters. And there is a website called medicines.org.uk. If you put any name of medication there, it will show you all the excipients. So even if your patient might say, well, I had a reaction to flu vaccine, you can look it up and you will very quickly find out if there is polysolvate, and then perhaps you should be concerned, or perhaps there was no polysolvate and the patient actually did not have an allergic reaction. Maybe they had a flare-up of the underlying urticaria. And I can share one more example with you today. A patient who was sent to us as allegedly being allergic to the vaccine. We did our workup, we vaccinated him. He had the most beautiful of vasovagal reactions. He was sweaty, he was clammy, he was faint. He thought he was going to collapse. But we just watched him. We allowed him to rest. We gave him water. We checked his blood pressure more for psychological reassurance rather than that we were going to do anything. And he got better. He got the vaccine. But the first time it happened, it was automatically in a vaccination hub elsewhere diagnosed as allergy. And I bet you're going to come across lots of patients who had a reaction like this, and then for some reason it all gets really, really complicated. Vasovagal reactions are quite common, and very often they are confused for anaphylaxis. So this is the sort of practical observations. But of course, if you have any questions, contact us either directly or via RuPaul, and then we are very happy to answer. And I think something has just popped up on my screen. Who is it for? All right, okay. So it is for both of us. Could we please share our contact details? With pleasure, and RuPaul can send it to everyone. And please drop us an email if you have any questions. I think both of us, Lesley and myself, we are happy to be contacted. Am I correct?
Absolutely, very, very happy to.
Exactly. And sometimes, this is all it takes. You drop us an email, 2 lines, we respond with 1 line, and everything is sorted. And then something that could be otherwise really complicated and delay vaccination or anything else related to allergy or obstetrics and gynecology can be sorted by very quick email. So yeah, get in touch.
Thank you both very much, and thank you to the audience for joining this evening. As Dr. Hunt requested, we will be sending out contact details along with the recording of this evening. So if you do have any further questions, please feel free to email to gpinquiries@onewelbeck.com, and I will direct to Lesley and Chris. Thank you again.
Thank you very much.
Bye, everyone. Get them vaccinated, please.
Bye-bye.